the answer is yes. It turns out that the polygenic risk score for coronary disease is effectively independent of the clinical risk scores, either the Q risk score used in the UK or the AHA score used in the US. In fact, it's almost independent of family history. And that's initially a bit surprising because polygenic risk scores are about genetics and family history is about genetics, we think. So what's going on here? I think it's one of those things where when you learn a surprising result, you kind of retrain your intuition, which it's a process I've been through. I think there are a couple of things. I think firstly, family history, the way we use it clinically, is picking up some element, this is a sort of obvious statement, but it's picking up some element of shared environment, and it may be that's rather larger than we thought. And also, family history is probably picking up the effects of rarer variants with larger effect, which aren't being measured or captured by polygenic risk scores. But interestingly, polygenic risk scores, because they're largely independent of family history, add to that information as well. So you can ask the question, suppose we already estimate risk by one of these clinical tools, and I'll use the Q-risk example from the UK, and then we think about using both the existing clinical tools plus genetics through polygenic risk scores. How does it change the results? So I'll give you a sense. So this is a schematic. This is an extrapolation from real data in UK Biobank. In the UK, there are about 10 million people aged between 40 and 55. And so I want you to think of that group here. These little stick figures thus represent about 100,000 people each. So the first question is, if we just use the existing clinical risk score in that group, it turns out that about 10% of the individuals, so 1 million of the 10 million, are above the clinical threshold for Stratton prescription in the UK. Then you can say, what if I change and I incorporate genetics as well as Q-risk? So the polygenic risk scores are independent of Q-risk. You should be able to do a better job by using both of them than just by using one of them. That's indeed the case. So the first thing is that when you combine genetics, there are more individuals above the threshold because you're doing a better job of estimating risk. And the second is they're actually different people. So to break it up, there were these 10 little stick figures, so about 1 million people who are above the threshold just using their clinical scores. So 8 of those, or 800,000 of them in my numerical example, are still above the threshold when you combine genetics. But there are 200,000 of them who are now below the threshold. So they had unhelpful traditional risk factors, but helpful genetics, which brought them down. But interestingly, there are almost 500,000 people who are above the threshold who are currently invisible to us using just the clinical risk scores. So they're people whom the clinical guidelines say we should be intervening and offering statins, but they're invisible to us. And we'd learn about them if we combine genetics and the traditional risk scores. And you can ask, because the data's there in UK Biobank, you can say, if I follow those individuals through time, is it the case that more of them in the group that we've now moved into the high-risk group get disease than those which we've taken out of the high-risk group? And indeed, that's the case. So a higher proportion of these people, the ones who are now above the threshold, have both coronary disease and cardiovascular disease than the proportion of these people who are the ones who were above the threshold, but actually when we do the more sophisticated risk estimation, are less, have a lower lifetime risk and a lower 10-year risk. So that's one example of combining genetics and non-genetic risk factors, and that's, I think, a natural way to think in general, rather than just thinking about the genetics in its own right.